this would help in saving lives. It will help improve service quality. You know how interrupted supply chain systems have led to even deaths of patients because we lack an item or two, have also led to very interference in the service delivery in our hospitals. And as usual, when we have an efficient supply chain system, we are very likely to reduce the cost of healthcare provision and in the overall lead to an efficient healthcare system. Then major challenges, I think most of those who work in the government and the primary healthcare sector, there's been a very big problem achieving financial stability. And that is why we face a lot of erratic supplies of our products, and also improving efficiency in the public pharmaceutical supply chain, which is attached to the financial ability, and even the technical working people are lacking, and sometimes because of lack of training, or sometimes even lack of interest. Then changing the perceptions and behaviors of providers, which is us, the patients, and even the public. Then also increasing cooperation between government and private sector. As had been alluded by Dr. Wanyanga, this is not very active or efficient as far as it should be. I know private to private is very okay, but public-private initiatives are quite here, there, not here, not there. Now, we're also regulating safety, efficacy, and equality. This is a big problem, and it's a very big challenge because you know, we currently deal a lot of generic products, and sometimes we may not be sure of the quality. But if this can be assured, then I'm sure we'll also be having very proper supply chain systems. And then how to manage pharmaceutical improvements and risks, that is another challenge that we have. Now, our role, I think involvement of pharmacists in this supply chain, that is active involvement, we are already involved, would reduce the inefficiencies and the expenses that come with this distribution process. Because when this is an efficient or expensive distribution system, they increase the final price to patients. And also, as you're aware, our system is majorly out-of-pocket payment system. And these inefficient systems will literally lead to quite hurt the families and finances in the largely out-of-pocket system. Now, increased import of generic products into the country. This is where the quality, safety, and efficacy comes in. If not assured, we may be having a very efficient system of distribution or having a last mile delivery of these products. But naturally, if the quality is not assured, then we don't meet our overall objective of saving lives. Then we also have, this comes as a result of stringent regulations on storage and distribution practices of health products and technologies. This is something we all know, and it is only us who can affect it. You can't leave it to any other professional to deal with this issue because these are health products and technologies. And then our involvement, as I have said, would ensure availability of medicines of highest quality, safety, and efficacy. Would also enhance the efficiency in pharmaceutical care and healthcare provision. This will lead to significant cost reduction, would broaden the practicing space. I can assure you there is quite a huge space here to practice. And I know we are currently faced by a very unprecedented unemployment rates for pharmacists. And so it is an area that people can consider to venture into. And then supply chain value chains is simply how do we add value in this supply chain system that already exists? What policies, what regulations, what initiatives can we put in place to ensure our role as pharmacists in this area is felt? Then finally, this is just a small demonstration. We have support activities and the primary activities in supply chain. So we want to see how infrastructure, human resource management, technology, procurement, policies, and regulations can be used to ensure we add value to the supply chain system in this country. I think that marks the end of this presentation. And so we would proceed straight to the panel discussion. And in this panel discussion, we will be having the panelists, Dr. Riungu, Dr. Wanyanga, and Dr. Evelyne Yeah, so we'll have the three of us making this the four of us, sorry, making the presentations. And so we will start by, our first presentation would come from Dr. Riungu, would be supported by the other two colleagues. And the first topic of discussion today would be on policy direction. So we asked that, what is the health products and technology strategies for the country? And what role do pharmacists play in that strategy? So I would like to invite Dr. Riungu to at least say hi and also take us through this while being supported by Drs. Wanyanga and Dr. Wanjiru in this area. And also remember to do your questions at Q&A. We may answer some of them real time, even as we discuss. So remember to put your Q&As on this section, the questions on the Q&A section. Welcome, Dr. Riungu.
Thank you very much, Preston, and the other panelists who are with us this morning. Good morning to all the pharmacists who found the opportunity to join us. I will go straight into the topic that we are starting with on the policy direction for HPTs. Allow me to quickly bring everyone to speed on why we are not talking about health commodities, we are not talking about drugs, we're just talking about HPTs. This is the new terminology that we'll be using moving forward to refer to the health products and the technologies. Because now we realize that for us to be able to provide care to our patients, we cannot just focus on the health products or the commodities alone, but also technology comes in as a key element of the service and products that we provide. Now, regarding the policy direction, you all know that for a very long time, we have been looking at different policies. In particular, we were guided by the Kenya National, I would say, pharmaceutical policy. I think the one of 2012. It was also called, what are we calling it? We were also calling it the session of paper, I think number 2 of 2010. Now, one very critical thing that everyone needs to know is that the policy, there were many policies looking at HPTs. And it wasn't possible, therefore, to have a very focused approach to HPTs management in the country, especially from the point of policy direction. And because of that, you may be aware or may not be aware that Kenya has now developed HPT supply chain strategy 2020-2025, and this is now ready for launch. It shouldn't be launched anytime. And that is the document that brings together the various policies to focus them on management, proper management of HPTs, so that we can achieve those objectives that Preston has highlighted in his presentation. Now, the health products and technologies supply chain strategy is therefore anchored on a number of policies. The most important is the Kenya Vision 2030, the one we refer to as 2008-2030. The other one is the Constitution of Kenya 2010, the Kenya National Pharmaceutical Policy 2012, the Kenya Health Policy 2014 to 2030, the Health Act 2017, and the Kenya Health Sector Strategic Plan 2018-2022. Now, the strategy envisions a sustainable and what I would call a resilient supply chain system that provides quality, affordable, accessible, essential HPTs for all Kenyans. Again, building on what Dr. Ochieng has highlighted. And this strategy covers a 5-year period, and it's a document that is very important for all of us. So we didn't need to understand why was it developed and why we didn't care so much about it, because it is the document that every pharmacist must read and internalize. Now, allow me to say that the reason why this was done is because there was very low implementation of the Kenya National Policy 2012. There is also an increased focus on HPT and gender as again evidenced by the USC and the Sustainable Development Goals, and also again persistent issues of governance of the HPT supply chain, and of course various assessments that have been done in the recent past. So the strategy, in maybe a minute, I would say focuses on a number of things. It has 8 pillars, and it actually encompasses all the aspirations for the HPT management in this country from both the public, the faith-based, and the private sector. So that is a document that is there, and I will not be able to dwell so much on it because of time. However, I will say it's a document that should be available to everyone, hopefully before the end of this month, as a reference document. But then the next question we want to ask ourselves is, what will be the role of the pharmacist in the strategy? One, I want to bring it to your attention that the Division of Health Products and Technologies has now been elevated into a department, and hopefully very soon it will become a directorate. Now, it has a very high concentration of pharmacists, and that means that it is expected to play a very key role in the oversight of all priority health programs, commodities, HPTs, and the essential HPTs. And therein, the pharmacist is expected to take his rightful role in as far as this is concerned. The pharmacist would have to be expected to take part in the implementation because the rollout will be done very soon. And also at the county level, be able to customize this strategy. So this is like a roadmap that has been developed for all of us moving forward, bringing together the various policies. And I would like to stop there so that I don't take up all the time and allow the other panelists to chime in a bit. Thank you.
Thank you for that presentation. I'd like to invite Dr. Wanyanga to have a minute to say something on the issue of policy direction. Thereafter, Dr. Wanjiru would also say something before we proceed to the next topic. Karibu, Dr. Wanyanga.
Thank you very much, Chair, and also what Dr. Riungu for making that groundwork for discussions. And let me say that I'm happy and pleased to know that a policy guide is soon going to be unveiled. Because what we have been relying on has been Kenya National Pharmaceutical Policy, which is now maybe out of date. Now, but I will not go into the details of that. I'll just mention 2-3 points where the pharmacist comes in. What is the role of the pharmacist? And when you are looking at that, we look at what are the factors that must be considered. One is sustainability of supply of HPTs. And in looking at that sustainability of supply, we must always have at the back of our mind that there might be disruptions like we have seen in this COVID era. Then number 2, of course, is looking at those, avoiding those disruptions. And one of the roles of the pharmacist is actually to make a risk analysis, make some investigations of what is happening, how long will it take place, what are the things that are likely to happen, and what needs to be put in place, especially considering what would be the priority HPTs that needs to be in stock. Then the other thing is helping the patients to get the best therapy for their care. Patients will always panic. When we saw everybody was rushing to look for masks with hand sanitizers and so forth, without caring what the quality of those products are. So the role of the pharmacist again is to help patients get the best care. And then the other role, of course, I've mentioned is quality of the products, being aware of dumping and counterfeits, which are likely, and substandard products, which are likely to filter into the market. But more important, be innovative and adapt to the new changes, bring in the new products and technology transfer so that we can be able to sustain what I mentioned at the beginning. So for now, let me just stop there and invite my colleagues, panelists to continue.
Welcome, Dr. Wanjiru, for a second or minute.
Thank you, Chair. Good morning to all our colleagues. Thank you, my fellow panelists, for what you've alluded to. So maybe my concern would just be, someone made a joke and said that Kenya has among the best policies in the world, but the challenge comes in the implementation. So probably what we'll need to do is we'll need to have continuous monitoring and evaluation when as the strategy is rolled down. And then it's also good for the people on the ground to have a feedback loop whereby even as we implement it, we're able to get a feedback as to whether we are meeting the expectations of the key indicators that are in the strategy that Dr. James has alluded to. Thank you, Preston.
Okay, thank you very much. I can see Dr. Ogaja is also concerned about the same thing, Dr. Evelyne. She's also concerned as to whether what are the guarantees of this strategy being implemented? From Dr. Riungu's perspective, I don't know whether you have some roadmap towards its implementation already, or it's just a launch that will take place. Maybe Dr. just for 5 seconds, could give us an answer.
Thank you. Those are very valid concerns, and we considered them during the development of this strategy. Remember, it involved everyone in all sectors, all stakeholders were involved. And one thing that is really clear in this strategy is that we have a very clear implementation plan that has been costed, and we also have an M&E, monitoring and evaluation framework that has already been put in place. We know that the strategy will cost about 464 billion to implement over the 5 years, and we have a funding gap of slightly half of that, which we are very certain that we will be able to raise from the stakeholders. So this will be self-propelling, and believe you me, it will be done if we all play our role as pharmacists at our different areas of practice. Thank you.
Thank you. That's very nice to know that at least here we have a strategy with all the resources needed to implement it. So fast forward, we go to, and this I would like us to spend the least time on because most of them have been discussed in the first section. Now, how then can pharmacists improve access to essential health products and technologies? To lead us in this area is Dr. Wanjiru, Evelyne, who would then tell us something about it before Dr. Wanyanga and Riungu would also make a point. Karibu, Daktari.
Thank you, Chair. I'm seeing most people in the chat are saying they can't hear me. I hope I'm audible now. Preston, please confirm.
Yes, I can hear you. I can hear you. Okay, you're audible.
Thank you. In terms of accessibility, it breaks my heart to realize that nearly 2 billion people globally have no access to essential medicines in the 21st century. And I like to quote what the former Director General, the WHO, Dr. Margaret Chan, said that all the donated drugs in the world won't do any good without an infrastructure for their delivery. So it comes to us back as pharmacists, who are the stakeholders, the commodity managers. We know that without products, there is no treatment. So we can take a lead role to ensure that there is accessibility to these HPTs. So how can we do this? Probably I'll start by saying we handle a lot of data at our various sites of work. Probably in the public sector, we handle a lot of commodity data. What do we do with this data? Apart from data entry, what do we do with this data? Do we audit it? Can we use it for data decision making? Can we use it to lobby for more resources, for resource mobilization? for strengthening our supply chains? Then do we do continuous monitoring and evaluation of our supply chains? I normally ask myself, do we have vague indicators that we can use to help us know what exactly is happening on the ground? For example, what is an acceptable stock out level? Is there anyone who has done any research on this, any paper, any guideline? Is there any guideline on how to monitor expiry or wastage rates? If we are not monitoring these few indicators, how do we know if we're improving? And all that will help us access our essential medicines. The other thing we can do is we should always create a feedback loop whereby in the primary healthcare that we can always get a feedback on whether the things we are saying as a best practices, whether we are getting them and implementing them in the right way. I think that's what I can say for now. And hand over to Dr. James.
Yes, Dr.
Thank you very much, Dr. Wanjiru. I think you've raised very pertinent issues, so I'm just going to add one aspect. Allow me to say that one of the reasons why this country has never been able to achieve commodity security, especially in the public sector, is because we don't know what we need. And that situation is prevalent even today. So then my recommendation to improve access would be, can we improve demand and supply planning, leveraging on quality data, like Dr. Wanjiru has alluded, because this data is generated at the last mile at the health facilities, but it is used at upstream supply chain to make important decisions for inventory or stock replenishment. So very important that we develop the capacity for demand and supply planning, what we call quantification. And in addition, because now health is a devolved function, we need to also begin candid talk about ring fencing funds for procurement of HPTs at the county level. Every county seems to have different priorities, and money for HPTs is not ring fenced. So it can be used to do roads, it can be used to do other things that are very little to do with HPTs. So those are the 2 points I wanted to add on top of what Dr. Wanjiru has mentioned. Thank you.
Yes, Dr. Wanyanga.
I just weigh into what Dr. Wanjiru and Dr. Riungu have said. Agreeing with them, I just want to add 1 or 2 points. One is the role of pharmacists is really to make sure that you have appropriate stocking, so that you have the right medicines, the right HPLs in the right place, in the right season, at the right time. Number 2 is public education, so that the users know exactly what they are going for. We need to be very careful with the public statement on some of these issues, so that education and science takes precedent of personal preferences. You need also to look at the quality aspects. How do we report bad quality through pharmacovigilance or through post-marketing surveillance? And this information, how is it used to protect public health, rather than how do you report for record keeping? I think that's a very key thing that we pharmacists need to play a role in. And maybe last but not least, how do we advocate? Advocacy and leadership in this area. If I'm in a specific district, county, how do I tell the governor that, look, instead of putting priorities on this area, we need to start with ensuring that the medicine, the HPATs reach the people so that they can remain healthy and productive. Over to you.
Okay, thank you very much. Now we'll move to the next area of discussion. And as you're aware, supply chain has suffered a lot during the uncertainties of COVID. And therefore it means that we need to have some strategies on emergency supply chain preparedness. And the expert in that area is Dr. James Riungu, who has even done a lot of work in that area with USAID. And I would wish that he takes us through that area, giving us the challenges, because we suffered a shortage of HPTs. We remember the PPEs, the sanitizers. We still suffer, actually. I doubt if the suffering has ended. And then he gives us the strategies now, both for the current situation and even in future. Then Dr. James, I would also like you to use an extra minute to answer two questions. That is, Dr. Ogaja is asking that who will take the leadership of the implementation of the strategy? She'd prefer that pharmacists take a lead role. And then somebody was also amazed at the figure of implementation, which is 464 billion. So maybe you may want to spend an extra minute answering that before we allow the other panelists to continue. Carry on, Dr.
Okay, thank you very much. I know Dr. Ogaja has really worked at the ministry for very many years. She has been really a thought leader in the area of HPTs. Now, so those questions and concerns are pertinent. Now, who will lead the supply chain strategy implementation? I mentioned earlier on in my discussions that the division of health products and technologies has been revamped. It is now a department, and very soon we are looking at a directorate. They will take charge in ensuring that there is full implementation. This strategy has the blessings of the CS, it has the blessings of the PS and all the top leadership at the ministry, because for very many years, supply chain has been the weak link in the health sector. Remember, it commands the second level of expense at the health sector in this country, yeah, in terms of finances. So it's a really key area, and the division is now, the department is being charged with the responsibility of ensuring that it is implemented to the letter. In terms of budget, we should not worry about the budget, because the stakeholders, the donors, and the other implementing partners are very excited about this strategy. And so far, like I mentioned, we have more than half of this budget already committed. We have commitments both from the ministry and different stakeholders and donors. And as soon we have initiated the process of bringing the stakeholders together to discuss how we are going to fund the gap. So in my opinion, it should be the will rather than the money. The money will not be an impediment. And Dr. Mbuva, who is leading DHPT, has told us that he has the full support and the commitment from the ministry to fund the implementation of this strategy. So I think together we will make it happen. Thank you.
Okay, now you can proceed to the issue on emergency supply chain preparedness.
Thank you, Preston. Emergency supply chains has been of special interest to me as a person because it is an important area for all of us to worry about and be concerned about. Now, we know that Kenya subscribes to the global health security goal of a secure world in response, it has developed the Kenya Global Health Security Agenda 5-year roadmap. This was developed in 2015. And it also established the International Health Regulation National Focal Point at the Ministry of Health. Now, but you remember very well during 2017, when WHO did the joint external evaluation of the IHR core capacities in deployment of medical countermeasures and medical personnel during public health emergencies, Kenya scored a low 1 point. 1 is the lowest, meaning you have no capacity to deploy medical countermeasures during an emergency. And therefore, the WHO Joint External Evaluation made a recommendation to prioritize the improvement of efficiencies in response. Now, based on that recommendation for Kenya in particular, the WHO started the initiative of the National Action Plan for Health Security. As part of that action plan was the emergency supply chain. How do we deal with emergency, supply chains during an emergency? And through funding from USAID again to the government of Kenya in 2018 and 2019, various stakeholders from including McKinsey, myself and my team, and a number of consultants, as well as the Ministry of Interior, the Ministry of Agriculture, Livestock and Fisheries, and the Ministry of Health came together to develop what we call emergency supply chain a playbook. Now, but even before I delve into really what happened and where we are today, it is important for all of us in this symposium to understand what emergency supply chain preparedness is and why it matters. Allow me to say that preparedness, emergency supply chain preparedness is actually establishing a system ahead of emergency to manage all commodities which are necessary to respond to an outbreak and ensure that they get to the point of care as efficiently as possible. So then why is emergency supply chain important? And we all know what has happened in this country as soon as we are struck by COVID. One, why it is important is because we know emergencies present unique supply chain challenges. One of them being that the demand is unpredictable and it requires timely delivery to save lives. We have seen that. Demand for even face masks, PPEs was unpredictable. Number two, emergencies put a strain on existing logistics system. We know KEMSA was totally overwhelmed. Our local supply chain systems were overwhelmed. And number three, we know that the resources that are required to respond to emergencies are complex and expensive. Remember how much we were buying the thermogans? Remember how much we were buying simple things like face mask. However, we all know that investments in preparedness actually pay off because preparedness saves lives by getting the essential medicines to the front lines rapidly. That money invested in preparedness reduces the amount of response funds, sometimes even by double. I would say even 50%. And we know what happened in our case, that we were spending too much money because we were not prepared. And that also we know that time invested in preparedness, again, speeds response. Again, studies have shown that it speeds response by over a week on average. Now, let's come to our situation and then ask ourselves, then what happened? I have indicated that there was investment to prepare this country. From 2018 and 2019, we all end up feeling that something wrong would happen. And in any case, we were used to some emergency infectious disease outbreaks, like I would say anthrax. It happened, I think, in Tharaka. We've been having sporadic cases of cholera and a few other diseases. But then we prepared, therefore, an emergency supply chain framework for this country. The document was finalized in 2019 and discussed by the Emergency Operations Center. This was under the leadership of Dr. Soti at the ministry. But unfortunately, perhaps we were all in denial that such things would happen because we had done simulations for all kinds of pandemics, all kinds of outbreaks, including the pandemic that came and what we needed to do. But then unfortunately, it was never deployed as it should. But at the initial stage of the COVID, I think sometimes before it was actually, it was made public in January and February, certain initiatives had already been started. And we know that we were relying upon the emergency supply chain playbook, which had been developed to prepare for response. And But then, unfortunately, as soon as the Emergency Operation Center was activated, it was taken over, and we resorted to our default, just the usual way we respond, and the framework was put aside. And that's one of the reasons why, in my opinion, we have found ourselves in the situation we are in today. So moving forward then, what I would like to say is that we must be able to use the frameworks that we have developed when there are no emergencies, so that we are not reactive when we face an emergency like this one. The framework, which I will be sharing through the PSK platform, maybe after the presentation, clearly outlines what needed to be done. It shows what data we have, what are the commodity forecasts for different diseases, including, we did not know about COVID, but we had done simulations for related conditions. When it also outlines the stockpiling strategy. What do you do? How do you do stockpiling? Warehousing and storage capacity in the whole country was mapped. Transport and waste management capacity was mapped in the public and private sector. And we are in different frameworks supporting materials, including what I would call, what I would talk about as protocols for emergency procurement. So that when there is an emergency, how do you fast track, for example, the acceptance of certain products in the country, maybe if they are not registered? How do you ensure that the suppliers do not exploit the system? All those protocols and being prepared, so that as soon as we have an emergency of that nature, they will be quickly customized. So I want to conclude by saying that we are looking at an missed opportunity. Kenya was the second country after Cameroon to develop that emergency supply chain framework, and it was intended to be used in a situation like the one we are facing today. But then, ladies and gentlemen, we still have an opportunity, because I believe more and more emergency infectious diseases are likely to come our way as we move forward in the future. And so let me say that we have what it takes. I think this country has the capacity, this country has the resources and the right brains to be able to avert the confusion that we have seen, especially in the public sector with regard to our response to deploy medical countermeasures during the COVID-19 pandemic. Thank you.
Thank you very much. I think we are running out of time, so I'll allow Dr. Wanjiru to talk about training needs that will make this pharmacist be more involved in supply chain management issues. And thereafter, we'll want to give Dr. Wanyanga a final opportunity to discuss issues on the KEMSA issue that is all over here with us. So Dr. Wanjiru, welcome. Can you discuss with us something on training needs that may make us more agile and ready to perform in the sector of supply chain for health products and technologies?
Preston, but before I talk about the training needs, I would like to throw back the ball to Dr. James about the simulations that were carried out in the headquarters. Was it possible to devolve the same to the counties, to have those simulations at the county level? Was it possible to devolve the same simulations so that we can have them at the county level?
Yes, we invited some county participants during the simulation, and we had also mapped the most at-risk counties who were to benefit from subsequent follow-on simulations. Unfortunately, it did not happen, but the materials are there, and we have the people who can help the counties undertake the simulations and prepare accordingly. We have in-house resources. Thank you.
In terms of the training needs, this is something that is very dear to me, because straight after graduation, during internship, we do rotations in the hospital, in the community, and then in the industry. And then after our internship, we are posted. Most of us land in hospitals. Some of us land in the sub-county where we are directly linked to the primary health. If you look at our curriculum in the school, we didn't have a very diverse study of supply chain management. So in my perspective, I think there's much more that needs to be done in the training, especially about supply chain, because pharmacy is diversifying and there's a gap that needs to be filled. So it's actually baptism by fire for everyone who ends up in the supply chain in the counties. I reached out to a few young colleagues who have graduated. We find that PPB has taken up the mandate to revise the internship program. Yes, they are being sent to the hospitals. Then after that, they go to the community, whereby they rotate from a dispensary or a health center. But the challenge is the facility in charges, the people who are receiving them, are not aware what exactly our young colleagues are supposed to do. So they'll go there, then they'll end up doing the same thing that maybe they were doing in a level 4 or level 5 that is dispensing. So at the end of their rotation, they still don't have that hands-on experience in terms of the supply chain management. Then I was of the opinion that probably as our interns come to the county, is there a probability that our county pharmacists can have a one-day climate setting with our interns where we tell them this is what we are expecting from you. You have a holistic approach to it. You'll move from a hospital, you'll go to a dispensary, you'll go to a health center. Then probably some of these facility in charges are our colleagues, are nurses, are clinical officers, but they don't know that that our pharmacists are being sent to them not only just to dispense, but to be involved in the whole continuum of care. So that was my feeling in terms of the training needs for the supply chain management in the curriculum.
I'd like to welcome Dr. Wanyanga to also say a word or two on that area of training needs. Yes, Dr.
Yeah, there's just one word again on level preparedness, and with a light note that Dr. Riungu talked of a budget for 467 billion. Sometimes I wish that we don't mention these figures to Kenyans because the money will be spent before the work is done. Then coming to, I mean, and when you're talking about preparedness, you know about the floods in Nyando, in Bodalangi, and so forth. And the question is, why is it that we are never prepared and we know that it's an annual event? So some of these things call to question. I wish we had more time now to dig into that. On training needs, we have a problem. The problem stands with the curricula. The university is not responsive to the needs of the country or the current needs of especially the current needs. At the moment, if you are talking about making Kenya the hub of pharmaceutical industry in the region, then it means the curriculum should be aligned with production. But still, that all the 5 universities or so have not taken that very actively. We still have got to rely on expatriates. We still have got to rely on technology transfer and so forth, because the training needs are not aligned to respond to the current needs. The other thing, of course, is on product development. The universities, these institutions look at product development, because when we are talking about the emerging diseases and the ones with a high mortality rate, we should have a response that connects that with the industry, and the training should now be focused in that area. That is shortly what I can just mention on that. Before, do I go straight to this other issue?
Perhaps I could add one point. I would add one point,
Yes.
just Dr. before you proceed, which I think perhaps has not come out clearly. The need to take a structured approach to improve preparedness of students, pharmacists, as they get into the industry. We could also, like you said, consider the introduction of supply chain courses in the pre-service training, and also develop and roll out, I would say, online supply chain courses for those already in service. So that if you did get an opportunity to learn, then you can learn online. And I know this is an initiative that has already been started by DHPT, like I said, in collaboration with the Health Information at the Ministry and the Health IT, that's the University of Nairobi. So something is happening in that area. Thank you.
Okay, thank you very much. So, Dr. Wanyanga, I'd like you to mention something on the harmonization of regulation and how it would lower or minimizes the effects or the allegations of corruption. That is, we are combining number 4 and number 6, where you talk about harmonization of regulation, and then you tell us how these allegations of corruption can be dealt with and how our involvement may help lower such, if there is anything of that kind. Welcome, Dr.
Thank you, Chair. We're combining those two, but I want to say they are very different so that nobody mistakes me that we are harmonizing corruption. There's no way we can do that. What we mean by harmonization of regulations is that we recognize that there are deficiencies in resources, be it human, be it finance, be it logistics and so forth. And when you harmonize these activities, then you use the available resources to do the same work. Now, in around the year 2000 and thereabouts, the Africa Union came up with a pharmaceutical manufacturing plan of action of Africa. This was to initiate, this was to make sure that we are self-sufficient and self-dependent on essential medicines. Now, as that was going on, the African Medicine Regulatory Harmonization came in because there was a gap. There are weaknesses in regulatory agencies. So you could not achieve much without that. And MRH initiative was started that initially started with the joint registration of medicines, joint inspection, and late joint pharmacovigilance activities and post-marketing surveillance. The ultimate goal is that we have a regional body called Africa Medicines Agency in Addis Ababa, which was supposed to be set up. Actually, the deadline is this year, that we have such an agency that would coordinate and harmonize the activities happening on the continent. We are unfortunate because most of the countries fall in between the least developed and least income countries, and only a few are in the developing stage like Kenya, and sharing these resources and expertise and the things we have taken place is going to be a milestone. So let me stop there because it's harmonization is just making sure that you use the resources available to do the best, you optimize what you are able to do. Now, coming back to allegations of corruption, and as I've said, they are not related. We are not harmonizing corruption. And I want to reflect back in the year 2000, much earlier, yes, it was around the year 2000 when KEMSA was formed. Before KEMSA was formed, and even before I go on, is what we are seeing today in KEMSA is a script that is well written. It's no news to me. It is the thing we saw before the year 2000, when you would go to KEMSA and find the stores full of expired medicines dirty boxes, poorly arranged, rampant shortages were the headlines of the day, and everything funny was happening. Everything bad in the sector was happening. And on 11th February 2000, the president promulgated or signed the legal notice to establish KEMSA so that we should be able to go through, make sure that there is sanity which has been introduced in the procurement and distribution of medicines. Now, I was lucky I have served at KEMSA board all this time and was instrumental in bringing the guidelines, the standard operating procedures, and so forth. Two things that I have seen today as we are seeing the problem in KEMSA that were there then. Number one is overstocking. And the area of overstocking is so that you maximize what you pay to the suppliers. Because once it is there and you have overstocked, at least the cut has been made is big enough. The other thing is leading to expiry of the medicines and then the warehousing space. So what we did at that time was to make sure we reduced, in fact, we closed a number of warehouses so that you just had just in time, things coming in and going out on a very clear procedure that number one, that you have 1/3 of the supply at the user point, one third in the process of being delivered, and 1/3 with the manufacturer. And this was meant to organize and make sure there is no overstocking and things are just gotten in time. And it also had the other benefit, and which we have seen, that the local pharmaceutical industry started to grow. And what missed, the gap that missed, and we need to look at it today, is the issues to do with the pharmacovigilance and post-marketing surveillance so that the quality of the medicines is enhanced. Now, one other example I will tell you, because we don't have much time, and this is also another real experience that then medical stores unit, we had civil servants who were employed, but the manufacturers had also employed their people who were dressing, coming to work sometimes even earlier than the civil servants and working overtime as though they were bona fide workers in that place. Their work was to pilferage the information to the supplier so that once you get one tender, his salary is paid. He didn't need any salary from the government. In fact, we had more than 20 or 30 people who were working there without salary from the government. Now, these loopholes need to be, I think we need to look at who is who there. The other thing that we need to also to be looking at pointers to corruption. One of the key pointers is when the law is being changed. What is the anticipated results? When we made sure that pharmacists take charge of KEMSA, at the time when it was to be a CEO, the technical fellow who was to debut as the CEO was a pharmacist, was making sure the profession, everything done according to the professional and the professional practice and ethics. When the law was changed, it opened a window now to start now saying, hey, what is there for us? And we need to be vigilant. We need to be vigilant, especially PSK. You need to have a very loud voice, very, very loud, that you can be heard, including even going to say, today we are going to occupy KEMSA until we have the right people in the right places, you have the right structure that can be able to deliver. And maybe at the moment close some of the warehouses so that we can start serving the end user who are the the county hospitals rather than breaking the stock and increasing and making the items even much more expensive. So the original plan is we need to go back to the default mode. And the default mode was done between the year 2000 and the year 2009, which are still in the books. We don't need to continue expanding when we know that expanding means that the budget is going up and the eaters are increasing and they are eating handsomely. So that's what I can say. The script is the same, and we can rewind it and be able now to say, how do we fix it? Bring the pharmacists back in place, have the organization structure in place, have the procedures, SOPs in place, make sure that you are not overstocking, just bring what is required in time, identify what is required and do quantifications properly together with the county governments. That's what I can say for now.
Okay, thank you very much, everyone. I know we've extended by about 7 or so minutes. Now, I want to thank everyone for attending this call, and I want to thank the panelists for being quite insightful in their presentations. And I would also wish to thank PSK for organizing a very seamless conference, and I'm sure we have benefited. To those who may not have answered their questions, they will be taken up in the form of Q&A, and we can follow up with the panelists as soon as we can through PSK so that we have answers. However, as noted, supply chain is a discussion we need to have as pharmacists so that we avert the several issues that arise in that area. And so it is something we need to pick up quite seriously. A quick one is that Dr. Riungu has a lot of material, I know, and I believe he should be able to share this through PSK that can be disseminated to all of us, and then we can have a look. Thank you, everyone, and sorry for taking a lot of your time.
Thank you, Dr. Preston, and the well-able panelists. As you've said, it's an opportunity to have more sessions to discuss supply chain so that people can be keep abreast with what improvements we can do. So well done, team, and we appreciate your involvement and participation. Okay, so participants, fellows, and fellow pharmacists, we've come to the highlight of the day, which is the breakout sessions. So let me take you through how the breakout sessions will be done. We have a total of 5 breakout rooms. The first one will be regulatory and PV. We also have business and entrepreneurship. Next. We have hospital, clinical care, manufacturing, employment in pharmacy. I believe at the point when you are registering for this conference, you actually got an invite to choose one of the sessions to attend. So I hope you made the choice. In case you didn't, we are sharing the links to each of the panels. It will be on your chat. So check on your chat shortly. You will get a link. So just click on the Zoom meeting link. When you get into the link, it will ask you if you want to leave the room. Basically, leaving the room means leaving this current Zoom meeting in the main panel and join in the main Zoom meeting for the conference. So you say yes, so that it takes you to the breakout Zoom link. The Zoom links are already active. Your moderators are waiting for you in those breakout rooms. So briefly, for moderator for the unemployment breakout is Dr. Esther Anyango, PV and regulatory Dr. Erimo Njuki and Dr. Angoi Mathenge. Dr. Hilary Kagwa will moderate clinical care. Business and entrepreneurship, Dr. Kamamia will moderate. And finally, for manufacturing, Dr. Daniela Munene will be the moderator. a few house cleaning announcements before we leave. Remember, after I end this Zoom meeting, you go to your breakouts, and that's where the day will end. So we'll not come back to plenary. So basically saying that we are the end of the conference is actually after your breakouts for today. So reminder, make sure you subscribe on the PPB portal for day 2 CPDs so that we can send you your CPD tokens and ensure that you are able to actually get your points allocated. Second thing, tomorrow we are starting the day. Okay, so everyone is on mute. If you have a question, please raise it in the chat room. Huh? So for tomorrow, we are starting the day at 8 a.m., 8 to 9, which will be registration, but we'll start the conference from 9 a.m. up to 1 p.m. I guess that's the only announcement I have. So again, please check on the chat, click on the Zoom link for the panel you want to join. When you join that panel, please say you want to say yes when that question pops up if you want to leave the room. If you are still stuck and you want help, we will remain in this current Zoom meeting to give guidance on how to join your breakout sessions. So I guess that's all from now. I invite Dr. Eva to make any announcements on behalf of the conference conveners and committee. Dr. Eva, are you there? Dr. Eva Amwai? Or she's already gone to breakout?
Dr. Miano, Dr. Louis here. So
yeah, Dr. Louis, President,
yeah.
Please.
Hi. So you won't hang up on this call so that everyone can, because if you hang out, the links will disappear. Yeah.
Yes, we'll stay in this call. Yeah.
Oh, okay, sir. All right. So let's exit. All right. Thank you.
All right, Dr. Louis. So we can take a break, 5-10 minutes break as you join the other meeting room. So please, moderators, don't start immediately. People want to have a bathroom break, but feel free to start once your rooms are in order. Thank you.
Hey, Doc, are we there? Oh, and I don't know how to share a presentation.